All right, welcome into another episode of For Your Health podcast, sponsored by Roane General Hospital. I am your host, Andrew Miller, and beside me today is someone we had earlier in our podcasting, and I'm very happy to have him back once again, Dr. Mousa Dajjani. Thank you for joining us today, Doc. I appreciate that.
Well, thank you for having me again. It's always nice to, talk about prescription for your health and all the updates and different topics.
And before we go any further, I want to wish you happy Daddery. You are the father of, I'm not sure when this podcast will come out, but I wanted to say congratulations.
Thank you so much.
On your
Appreciate
newborn.
it.
So good stuff. You're sleeping well, apparently.
Yes, absolutely. Right.
Yeah, well, so Dr. Dajjani is a family medicine practitioner here at Roane General Hospital, and I wanted to go back real quick with you, Dr. Dajjani, to give just a real quick brief history of how you ended up here at Roane General Hospital, where you studied and where you residenced, and then how you made it here real quick before we start talking about a very exciting topic, as you were talking about with based off of that GLP-1s we had. So we're going to talk about a very interesting topic, but I wanted to give the people a chance to remind them who you are.
So basically I was born in Canada, and then I did my undergrad at the University of Toronto. I did biology and psychology. That's when I kind of got interested in medicine. I applied to medical schools, but I ended up in the Caribbean, actually. So it was a nice way to study with the beach in the background. And then I got lucky to be able to match in residency here in Charleston, West Virginia at CMC. I matched in family medicine, a 3-year program. After almost before graduation, I was trying to figure out my plans. And my wife got a job at the cancer center as a genetic counselor. And then I had the opportunity to look into different practices here. And something drew me into West Virginia. It is beautiful. Everyone is so nice. Medicine here, there's a big need for physicians. So really, it just kind of drew both of us here. Now we started a family, as you mentioned earlier. And then I had looking around into the communities, and I got lucky to be able to meet with Doug, talk about the opportunity here, and he told me about the need for physicians, and he talked to me about the community. And the moment I came in here, I just knew this was going to be it. So I ended up here. I'm actually almost finishing my first year.
That is
next month.
It is wild that you've been here now almost a full year.
It's hard to believe, but when you have a good time in terms of loving your job and being able to help and making a difference, it kind of flies by. So I'm really grateful, and I'm looking forward to further improving my career and staying here.
Well, we're very happy, obviously, to have you. I love that the search crew, including Doug, really does a good job of recruiting providers from all over and bringing them here. And I'm glad you're one of those, Dr. Dajjani. We had a good time talking.
Oh, yeah.
The first couple of podcasts. We were talking on one of the podcasts about the excitement that you and many others have for the GLP-1 medications. Let's touch on those real quickly. What are the GLP-1s? And tell us some of those better names for them than GLP-1s. Of course, people know that right now because there is such a excitement over these things.
They keep developing. You can see it everywhere on the ads, and you hear about them, right? Especially with diabetes, but also with weight loss. So GLP-1 agonist is what we talked about, is the medicine that helps basically suppress your appetite to improve weight and also decrease your glucose by increasing insulin production. So basically what happens is there are diabetes medications, and brand names would be Ozempic, Mounjaro, or Trulicity, Victoza. These are your shot, whether it's a weekly shot or a daily shot based on the brand or the medication name. And these are the medication we talked about. They have some benefit in cardiac patients with weight loss, but also we need to talk about the side effects and when to start them. So that is the class that we were talking about last time, and they're all mostly injectables. And that's where we mentioned the class for that medicine.
Yeah, so GLP-1s, very, very good. And again, you were very excited to talk about those. What we're going to talk about today off of the back of that is these sodium glucose co-transporter 2 inhibitors. Now, I had to look down for those people. I hope that you don't look at me on that one, but they're called SGLT2 inhibitors. And I know this is another thing you're very excited about with regard to diabetes and regard to specifically type 2 diabetes. Before we get into the drugs themselves, let's talk about the difference between type 1 diabetes, type 2 diabetes. Many people probably know the difference, but there's probably plenty of people out there that may watch this who truly don't know the difference between the two and what that means for people who have both or have one or the other.
The best way you can describe this is we have cells, the pancreatic cells called beta cells. They help produce insulin. So type 1 is where your immune system attacks those cells to decrease the ability to produce insulin, so you don't have enough insulin. So hence, people need to be on insulin for a lifetime. That's type 1. And usually, because it's an autoimmune or immune modulated disease, it occurs earlier. So you see a lot of adolescents or teenagers, younger in childhood, they'd be on diabetes. Type 1, they'll be on insulin. Type 2, however, is almost lifestyle or almost occurs later, because you do have the ability, the pancreas has the ability to produce the insulin, the beta cells are intact, but the sensitivity to respond to the insulin sensitivity is reduced. So you have increased sugar, the insulin is there, but it's not responding as much. So it's kind of like occurs later on. So type 2 is you have enough insulin, it's just not responding to the signaling. So you need a little bit of push where you have like metformin or GLP-1 agonist or SGLT2 inhibitors. What we're going to talk about is to help promote that, either get rid of some sugar or increase the sensitivity to insulin.
Yeah.
Basically, that's the difference.
So you say that type 1 diabetes is more on the lines of something that can happen as an adolescent. It's more, if it's an autoimmune thing, it's not something that is so much lifestyle based. This is type 2. Are either of those mediatable, one or the other? Can you get rid of type 1 or type 2 diabetes?
I would say, to keep it, I would say type 2 is almost, because it's lifestyle, you can basically help improve it. And sometimes I've seen patients achieve goals, and some of them, they're diet controlled. However, with type 1, it's almost because you don't have enough, you're not secreting enough insulin. You need to be on the insulin because you're not having anything to respond to increase, like glucose. So unfortunately, but you can control type 1, you just have to watch it. They're always on glucose monitors. They always have to be monitored closely, but you can have it controlled. And as long as you do proper carb count, you follow up and you take your insulin, that also can be manageable. Yeah. But obviously, sometimes it's one of those things where you don't have enough, so you have to get replaced. It's just like a thyroid disease. I know it's autoimmune as well. You have to get thyroid replacement because your thyroid is not producing enough of your hormone.
So that's the basics for this, and we're going to talk about these SGLT2s that you, again, are extremely excited about. You came in here saying, we're going to talk about some exercise and how this stuff affects exercise.
Absolutely.
What are SGLT2 inhibitors? What do they do? And then what are some of the brand names we may be hearing as they maybe become kind of very exciting as well as the GLP-1s?
It's interesting to say brand names. I think if I say the brand names, people will recognize the brand names because you see it on the ads. But I guess talking about the mechanism is very important before we get into the brand name. So SGLT2 inhibitors are a class of medication that were initially used for type 2 diabetes management, but now there has been actual uses for other conditions, that even if you don't have diabetes, which we'll talk about that. The way they work is they target a protein on the kidneys. So when usually the kidney reabsorbs the sugar as we excrete the urine to filter out, to reabsorb. And by blocking that protein, hence it's called an inhibitor, so it inhibits the co-transporter. So it helps pee out or excrete all that sugar out. And that helps with improving the glucose levels and helps with improving diabetes. So instead of your body recycling sugar and restoring it again, basically it flushes it out. So that's what SGLT2 inhibitors do.
And that's what is very exciting about those.
Yes.
When you were talking about, obviously, the treating of type 2 diabetes, as you said, that can be lifestyle based. When you are talking about sugar being eliminated by way of urine, when the body is looking for energy, it gets energy in certain ways, right? So what are the ways that the body does get energy, and why is that so important and so exciting because of this?
So the carbs is one of the main sources, and carbs become sugar, right? So even if we eat like bread, that's carbs, it's stored as sugar. So when you pee out all that sugar, excess sugar, your body initially relies on sugar for energy, but if you're peeing out all that sugar, it starts relying on other sources like the fat. So it's fat utilization, which actually we'll talk about the benefit, but it has a modest weight loss benefits, not as much as GLP-1 agonists, but that's how you achieve some of that weight loss, obviously with lifestyle and exercise. But that's how you shift from using sugar and carbs for energy to fat utilization and using the fat to absorb it from there. So hence you help with weight reduction.
Not as if I would be using those right now, but I could really use some fat burning instead of burning other things. I certainly, lifestyle-wise, put plenty on. Seems so hard to take it back off. You know, once you put it on, it's very, very difficult to take it back off. So we talk about how these medications work in that it takes that protein, it inhibits that, it's an inhibitor, and then you're able to excrete the sugars instead of bringing them back in. And they are used as energy, but instead it goes straight to using the fat for energy, which is really, really nice. How does that differ specifically from the GLP-1s?
In terms of like weight or just the way they work?
Just the way they work.
Well, a GLP-1 agonist is a protein that actually binds into your, like I would say, intestinal tract to helps send signals to your brain that you're full quicker, and it helps stimulate like insulin sensitivity, and then that's how you lose weight by appetite suppression. This is a whole different thing that acts on the kidney that inhibits those co-transporter to excrete the urine, the glucose to the urine rather than reabsorbing it. So they're a totally different mechanism, totally different mode of action, but they both achieve the same way. And the end goal is that glycemic control and improves blood glucose levels, right?
So obviously you're very excited about these as well as the GLP-1s. Let's talk about some of the actual benefits, potential benefits, and then maybe a side effect or two that you may be seeing. Again, as you were talking before we came on here, with all these things when you're talking about, you know, athletes and things like that, every good thing you need to make sure you're doing the correct stuff on the side. But what are some of the really nice benefits that you're seeing and that you think you'll see as this becomes even more, I don't know if I want to say relevant, because you're in this and you say, well, this is out. I mean, this is not something that people don't know about, but this is what I'm hearing for the first time. So if you're me, what are some of the really good benefits for this?
So the good benefit obviously is the type 2 diabetes control, so better glycemic control. So let's say you're diabetic, you're on metformin, you go to the doctor, and let's say, you know, you're looking for something to improve further, either a GLP-1 agonist or an SGLT2 inhibitor is the best next step because of their benefits. And it depends on your goals, and also because insurance coverage and stuff like that, they're more actually achievable by less, I would say, obstacles with SGLT2 inhibitors, because they're also used for other benefits too. And they're not injectables. I want to say that they're all oral, like pills. Taken, yeah. So the benefit is glycemic control. And then two, it is a diuretic in a way, because when you're peeing out all the sugar, excreting the sugar, you're having some of that water loss. So it helps with that weight reduction in that way alone, plus, even though it's a modest improvement. But then also, again, the third one is the fat utilization and metabolic flexibility, which is instead of relying on carbs and sugar, you start relying on the fat for improvement. So that actually helps if you're implementing exercise and lifestyle changes. Now, when you talk about athletes, right, if you're following a low-carb diet or a keto diet, think about it. You're on a low-carb diet and you're excreting all this glucose. Where is energy going to be shifted from when you exercise, right? That's when it goes to the fat. So you have better fat burning, and then achieving weight loss. And then you have better energy, right? Side effects. So obviously everything has side effects.
Nothing is gold.
I mean, if you look at Tylenol over the counter for side effects, you'll have a list of things. So this is why I tell patients, every medicine, no matter what, you have to look at side effects, even if it's over-the-counter Tylenol or ibuprofen. Everything has side effects. So you just, as long as you do education and you have shared decision making, and patients are aware and what to look for, and obviously what benefits and what's weighing the risks and benefits. If you think this is more beneficial for the patient, with obviously patient not tolerating, then that's way to go, right?
Yeah.
So think about it. If you're excreting glucose in the urine, and you're having more water loss, so the first thing they're going to notice is you're going to pee out a little bit more.
Yeah.
So more increased urination. Usually that's noticeable in the beginning, and that should get better. So it's almost like a diuretic. The second thing is bacteria loves glucose. So when you're excreting all this glucose in the urinary tract, bacteria likes to be attracted to that. So you have to educate patients that UTIs are very common as a side effects. Now, who should not get this medicine? If a patient has a history of recurrent UTIs, so they have multiple UTIs throughout the year, you don't want to start that because they're at risk for increasing infection. So you don't want to start it, right?
Yeah.
You tell them to increase more fluids, more water. You talk about hygiene. That should prevent those UTIs. And then the third thing is dehydration, because you're losing all this water. So you want to talk about, we just said it, increase hydration.
Yeah.
Now, for athletes or even patients who want to exercise, because it is a diuretic and because it makes you, it can cause you to be dehydrated, it is very important if you're exercising and you're on this medicine to stay hydrated and make sure you are, because you're going to have increased risk of just feeling more dry or being dehydrated, lose your electrolytes while on this medicine.
Yeah.
And then the last one, which is very important, is it can have a rare but a very serious side effect called diabetes ketoacidosis. Just cause a shift in your pH and increase sugar. It can cause, makes you stay in the hospital. But that's a very rare, very, very rare. But it's just, we always educate the patient on it too.
So I assume, just like anything else, it's dependent upon the individual.
Yes.
It depends on their body composition, how they can't handle this kind of stuff. And obviously, even with that rarity, you have to mention that small thing.
Absolutely.
Which is
100%.
So when we're talking about physical activity for people who may have type 2 diabetes, their nutrition, what do you see as, or what is happening when it comes to these SGLT2 inhibitors? What are some of the things you're seeing as far as people utilizing them in with their nutrition? Are they changing? Do they have to change their nutrition habits? I think you would have to anyway if you're trying to be more physically active. But is this more of like a crutch that you can? I like that smile. You still are going to tell them you want to eat better, you want to eat the proper foods, and you want to get some exercise and activity. Is this something that can help spur that on? Is it something that can be used kind of supplementally for people with that type 2 diabetes?
I would say no matter what, with type 2 diabetes, you have to counsel on nutrition and the lifestyle changes, right? This medicine is helpful. It can have the additional benefit to that versus, like taken as a supplemental for that. It's mainly for diabetes and other causes too, which we'll talk about shortly. But if patients are aware of how it works, and they can actually low carbs, because that's what, you want to do, you want to improve your diet anyways, then that benefit. So technically, in a way, it is a supplemental addition, but not a direct thing, So I think as long as patients know the benefits and how it works, and if they actually count their calories and do the low carb, they can find additional benefits.
Yeah.
But usually athletes, or if they're following, if patients have to follow the low carb like constantly, which is very hard. But just knowing that if you exercise and you're on this medicine, knowing that metabolic flexibility that you have with it is that benefit alone, everything adds up, right? Think about it. That's how it works.
Let's talk about those other things that it's helping, that it can cause. You're talking about type 2 diabetes. Obviously, did it come from that, though, just like the GLP-1s, where you said, well, initially designed for that, and then you guys have found, or the studies have found, these other benefits for GLP-1s? What are you seeing are the other things that it can really do a good job with?
So this topic excites me because of how much they've done research and how much benefits they found on these medications. So I want to mention the brand names that we want to talk. So,
I was waiting for that.
So Farxiga, Jardiance, Invokana, these are the ones you see. And the SGLT2 inhibitors, they all end in flozin. So empagliflozin, dapagliflozin. So canagliflozin, that's the name. But then the brand name is what we talked about, Farxiga. You see all that on the...
Yeah.
So let's talk about other benefits. So you see on advertisements, you see heart failure with Farxiga is very common. So what happened is this was initially developed for diabetes, and then they found over the years that patients who are on these medicines, that their kidney functions have either slow. So patients who have diabetes are at risk for having kidney disease because of in the long term if it's uncontrolled. And then they found that patients who have either they have already underlying kidney disease or they don't. They found that patients who are on SGLT2 inhibitors have slowed the progression so that their kidney disease did not worsen. So they did more and more studies, and in fact, they did find that these medicines, because of this mechanism, that also improved kidney function or slowed the progression. So in fact, it actually helps patients with kidney disease and prevent kidney disease as well.
Wow.
So now you'll see patients with diabetes. That's why I tell patients I technically should have them on an SGLT2 as one of my top 3 choices if they're uncontrolled, because that will actually prevent, or help slow the progression. So the kidney doctors now start the nephrologist, they start them on it, and it's pretty good. And again, with the side effects, weighing the side effects and the benefits as well. And the good thing about these medicines is they say you can continue it until until patient undergoes dialysis. So like you can see, even if the kidney function is low, you can still continue it because it helps prevent that. So that's for one of the other benefits.
That's pretty major, by the way. Are you leveling these up or something?
I mean, it's exciting. I like it. Yeah, I mean, it's pretty good because if somebody with kidney disease and they can't take certain medicines, you can think about starting it if there's no contraindication or issues with starting it. Now, the second one is also pretty exciting with the other specialty, cardiology. So patients with heart failure are using this, the Farxiga or the Jardiance, because it actually helped improve heart function and slows the progression with heart failure specifically. So if you have your heart's not pumping enough, these medicines are used. And the same way they did studies, and they found that patients with this heart failure should be on, as part of the regimen, should be on this. Now, they actually did there's something called goal-directed medical therapy. This is a term used by the heart doctors, the cardiologists, to place patients on certain medicines to improve the heart function. SGLT2 inhibitors have been added officially to that list. So patients with heart failure should be on Farxiga and Jar based on the number of the ejection fraction.
Wow.
So whether or not you have diabetes, patients who have heart failure should be on, like they are on SGLT2 inhibitors.
How does that work? How, when it comes to...
So
I know, sorry to get way into the weeds on this one.
No. So for the cardiac, honestly, I'm not pretty sure, but I think what it is I think it's through the mechanism of that too, but with the kidneys, but I'm not sure how the added benefit. I need to do more research on that, but I know the indication for it.
Yeah.
And I think what it does is with the diuretic effect, possibly has some role in it too, because part of the heart failure treatment is fluid. They get fluid overloaded, and it does help with the diuresis. But I mean, these are the indications, and they're pretty interesting, right? So whether you're not diabetic, patients will be on SGLT2 inhibitors, and then they place them on lower dose so that doesn't have much effect on, like the sugar. If they're not diabetic, you don't want to drop too much. But again, usually it's not added alone for diabetes; it's always an addition. So that's a good way to think about it too. But it's pretty interesting.
So for kidney issues, for heart issues,
yes,
something that was designed as a supplemental thing for type 2 diabetes. That is very, very interesting. No wonder you're excited about this. No wonder you're excited about this. So you have your practice up there. You talk with your patients. How much of this have you, I mean, how many patients do you have that have this kind of stuff where you're starting to branch out? I mean, I don't want to get too far into it with you when it comes to how you diagnose your patients or how When do you put that in? When do you say, like, if you look at somebody, maybe they don't, is it something if they don't have type 2 diabetes, or even something cardiac wise, or even something kidney wise? Is it something that you even look at with them?
Oh, absolutely.
How
Yeah.
does that I mean, how do you do that?
Well,
How do
honestly,
you doctor?
how do you doctor? So the way I doctor is no. Well, honestly, it just comes from. Well, I attended this conference in Tampa, and it was about the diabetes summit, and that's when they talked about all these studies, and that was before I started my practice here. It was my end of my residency. It was such a life changer for me because that's when I developed such interest and I more into these classes of medications. Honestly, it all depends on the patient. So, for example, this is just a very simple example. A patient who had swelling, shortness of breath, and got newly diagnosed with heart failure, heart's not pumping as it should, right? Comes in, and then you think about what I talked to you about, the goal-directed medical therapy is all the list of medications that you should be aware of to start them on, knowing that SGLT2 is now added to it, and knowing that myself, when I'm not a cardiologist, but I know that by the time the patient sees cardiology, but they want to see the family doctor first to get a referral, why can't I start them on and then refer? Which I had a couple of examples like that, and I started it, and then they continued on it, and then it actually been helpful. And the cardiologist will either adjust the dose or keep it, or depends if patient's tolerating. But that's how we do. So heart failure, think about, okay, SGLT2 is now indicated. Let's start it. Kidney disease, right? Patients who have kidney disease, they're not able to see a nephrologist. They haven't started the SGLT2. If they don't have diabetes, they're like, you know what? Have you ever been on this medication? No. There's a side effects. Have you ever had UTIs? Not much. I'm staying hydrated. I'm willing to try it, and then get them referred until they see you can start it. So there's a lot of ways you think about it. So the doctoring is all based on this here. But for me as a family doctor, the way I use it is mostly somebody's diabetic type 2, not controlled, and let's say we tried. We think about the benefits. They have some reduction in kidney. It's an additional benefit. I do prescribe SGLT2 inhibitors as long as they tolerate it. Sometimes I add it to the GLP-1, and all depends on also individual basis. Side effects, history, because remember GLP-1s, I don't know if you remember, but if you have history of thyroid cancer or pancreatitis, you should not be on a GLP-1. So it all depends individual basis. And also, if a patient is not seeking weight loss and they can't tolerate, they get nauseous, you can't be on a GLP-1, then SGLT2 inhibitor is actually a better option. So I've prescribed a lot of SGLT2 inhibitors in addition or separately, as long as they tolerate. And then obviously you need to watch. And I wanted to mention one more thing. Dehydration, water excretion can cause a little bit of drop in blood pressure if you stay dehydrated. So always something to watch for. But
Stay hydrated.
Stay hydrated, and then these are the common side effects, but they're pretty tolerable, and a lot of patients are on it. And as long as you do your practice right, which is prescribe medicine, follow up shortly, and make sure they tolerate, I think it's been honestly life changer.
You did answer one of my questions during your answer right there, which was, is this something you can use with GLP-1? So you obviously can use both those at the same time.
Yes,
then.
absolutely.
Okay.
Actually, based on the guidelines for the American Diabetes Association, if you look at the guidelines, there's a whole stepwise process. Usually metformin, or depending on type 2, obviously the metformin, and then they say add this, and if there's kidney, they say like add SGLT2. If they're common like comorbidities like severe like morbid obesity, and you want to consider other like weight loss benefits, more so go to GLP-1. If not, add a SGLT2. So heart failure, SGLT2. So it's kind of a whole different world.
It all depends on the individual.
But you can actually, the risk of hypoglycemia, which is low sugar, is not as much because you're not on insulin. But if the patient is on insulin, you can still add an SGLT2.
Okay.
As long as they're monitoring and as long as they're not dropping too much, So it's all individual based. It's all, again, shared decision, what we decide together. I always ask the patient, make sure they're comfortable with the choice. Instead of saying, oh, this is what I want to start on, here you go, you know what I mean? I'd rather talk to them about the choices, see if they're comfortable. And then also, insurance coverage. Sometimes, Now, the SGLT2 inhibitors is on a program on certain pharmacies called 340B pricing, which is a discounted pricing. I think some pharmacies have that, so patients can get a discounted on that medicine. So it's pretty affordable in certain cases too.
Well, no wonder you're excited about SGLT2s. You were equally as excited when we talked about GLP-1s.
GLP-1s, right?
Do you have a favorite? Which one's better than the other?
No. I honestly like them when it works for the certain situation and the patient tolerates it, and when you see results. And that's the rewarding part of being a physician, is being able to improve and being able to see the benefits, and especially with the added benefits. For example, the GLP-1s with the cardiac benefits, and then the SGLT2 inhibitors with the other benefits. And even if you don't have heart failure, just by improving heart function in general, it may improve endurance with exercise too.
Yeah.
So
big ideas, man. Very big things happening here with these SGLT2s. Dr. Dajjani, thank you as always for joining us. I know you're a busy man. You're even busier now that you have a newborn at the house.
Yeah.
I'm glad you're not stressed at all and you're sleeping perfectly.
Oh, very perfectly. Yeah. I'm getting 8 hours of sleep.
Yeah. Well, Dr. Dajjani, if people want to go see you, how do they get a hold of you real quick?
Oh, so Roane General Medical Clinic, 304-927-6822. That's where our practice is. And also, now it's a new, I'm starting to work at a Walton Clinic. For now, I'm going to do every third Friday of the month, and then we might expand it to twice a month. But my first clinic day in Walton is actually on the 18th. So I'm pretty excited.
All right.
I drive by Walton, but I've never been, so it'll be exciting.
Fantastic. We were out there doing a live remote for their grand opening. We said, well, when we talk about Roane General Hospital, their tagline is care you can trust, close to home. It's now closer to home for many people. Dr. Dajjani, thank you once again for joining us. So much fun. Folks, if you want to get a hold of Dr. Dajjani, get a hold of him up at the medical clinic. And watch out for these SGLT2s. Very good stuff, folks. Thank you all for joining us once again.